first speaker in this session is Dr. Irene Wapner, and it's wonderful to have her here. We've worked together for a number of years and have a few studies that we've published together. She is a full professor now. The program is incorrect, but so congratulations, she was just promoted. So Dr. Wapner was just recently promoted. She's a full professor in the Department of General Surgery, and she's going to be talking about changing role of surgery in breast cancer.
Thank you. So I'd like to talk about how surgery has changed over time and hopefully how surgeons have adapted to these changes. And so I'm going to be switching my perspective back and forth a little bit as I talk about different topics. So surgery has changed over the last 100-some years, and so has the role of the surgeon. So in the past, it was very common for a surgeon, certainly in the 20th century, to come out and say, you know, I got it all, you don't have to worry about anything. And, you know, today that's really not the way it is. And fortunately, we have had many advances that have contributed to better outcomes and also better, quality of life overall for our survivors. So I'm certainly taking the perspective of the surgeon. The surgeon today, if you happen to be affected with breast cancer and often meet a surgeon first, surgeon must be familiar with all the other treatment modalities that are available, and especially be tuned in to understanding and interpreting the molecular markers when you have a new diagnosis of breast cancer. The surgeon's often the one who orchestrates the multidisciplinary care of a patient, more often than not, because the surgeon may be the first person to see a patient who might have breast cancer. And to bring up the topic that Dr. Westphal and I have worked on, the surgeon, I feel, should not overlook his or her role in thinking when they see a young patient that there are many other issues that are important to that patient, such as their future childbearing capacity and how the treatments may affect, and the diagnosis may affect their preservation of their fertility and their future childbearing capacity. So the surgeon can be key in guiding decisions and often also key in an important element in deciding nowadays what is the sequence between surgery and systemic therapy. In the past, it was always surgery first, unless you had very locally advanced breast cancer. Today, how we do that and how we approach that combination of treatments is not always surgery first. And also it's important for the surgeon to know when not to operate. So perhaps you've seen these statistics. If you look on the right, the left panel represents the incidence of male breast cancers, with prostate being the top of the graph. But for women, as you can see, the pink line in the graph shows us that overall, over time, breast cancer has been the most common cancer in women. And it sort of hovers around the same incidence, about somewhere between 125 to 130 cases per 100,000 population. But the good thing is that it seems that the death rate has gone down about 25 to 30%. And I know that it's not clear-cut. These are the statistics. There may be other people who interpret them and feel that maybe this is a result of overdiagnosis, and I'm not sure that I can clarify that answer, but I think the trends are promising. So breast cancer presents, and this is, I'm trying to share with you some information that may be valuable for those of you in the audience that have not had to confront breast cancer. So it can certainly present as a palpable lesion, and most of the times when it's palpable, it is also seen by one of our breast imaging modalities, which can be mammography or ultrasound. But many times now, cancer is really silent. It can't be felt, and it can only be picked up in a screening study. So cancer can be detected by looking and examining the breast, by feeling a breast, or as I alluded to a few minutes ago, by a screening mammogram. So screening of asymptomatic women became sort of our national health policy starting in the early 80s because of the Breast Cancer Detection and Demonstration Project, which showed that screening mammography was associated with saving lives. And we can discuss this later, but I would say that right now there are many steps that happen between screening, detection, diagnosis of a breast cancer, and potential deaths. So I think associating, personally, this is my opinion, associating screening practices with death rates is much more difficult today because many other things can intervene and detract from the benefit of screening. So when do we use other imaging modalities to help us find breast cancer? So here is one common one, and now in California, breast density is a new finding that introduces the possibility of using other imaging modalities to find breast cancer, and MRI and perhaps dedicated full breast ultrasound or other ways to assess women with dense breasts. So this is also an example of someone who can have very dense breasts and have a cancer that cannot be seen by mammography but can be seen clearly on MRI. So in general, our treatment strategies are a combination of surgery. The goal of surgery is to remove any clinically evident, that is, cancers that you feel, or radiologically identifiable disease. Radiation is used for enhancing local control and decreasing local recurrence. Overall, radiation has a very minor role in terms of overall survival. And systemic therapy is the one, and I think you've heard some comments about the use of systemic therapy for those of you that heard Dr. Pegram today. It helps us reduce the risk of cancer recurrence in the breast and elsewhere. So radical mastectomy was part of the medical dogma for a long time. In essence, it removed the breast, the muscles, all the lymph nodes, and that picture that is kind of hard to look at is of a patient who was treated sort of, I think in the 1960s, and had a radical mastectomy and had quite a disfigurement that has accompanied her into her mid-80s. But there were two men that are probably the most notable surgeons worldwide. One is Bernard Fischer from the University of Pittsburgh then, and Umberto Veronesi from the European Institute in Milan, who both kind of rebelled against this dogma, the radical mastectomy, and felt, and especially Dr. Fischer had done laboratory work to begin to show that breast cancer from very early on can be a systemic disease. So it made no sense to have these radical surgeries because it didn't really address the problem. The problem sort of had already gone elsewhere, so removing more tissue locally did not achieve a greater cure. So both of them proposed, and both of them led very important studies, and there were a few other studies in Europe too, that began to compare doing this operation, a very radical removing of the entire breast, with just removing what we now call a lumpectomy. So in essence, all these studies have shown equivalency both between mastectomy and lumpectomy. And that really was a very dramatic change that happened almost 30 years ago. But sometimes changes in medicine don't catch on that quickly. And it's still very common for me I hear this every week from patients that I see with breast cancer, that their sort of emotional reaction is that if they have a mastectomy, it should be better. It should control the disease better. And I think more often than not, that is an emotional reaction. And it's part of what a surgeon should do is to take the time out to sit down and talk to the patient, explain what the medical evidence is, what you get from one operation versus another. So since about the mid-1980s, there's essentially been two options in the treatment of breast cancer. One is on the panel on your left, the so-called modified radical mastectomy, which removed the part of the axillary lymph nodes, the regional lymph nodes, along with the entire breast, versus just removing the lump and the lymph nodes. So in assessing patients for which type of surgery, tumor size is a big issue. So we can only really offer lumpectomy based on these clinical trial evidences when the tumors are sort of about the size 2.5 inches or smaller. And nodal involvement, although people often think that if my nodes are involved, I need a mastectomy, nodal involvement does not dictate what type of surgery in the breast. But it is very important to have this clinical assessment that a surgeon feels under the armpit to detect any involved nodes. And so we have certain size criteria for what you can see there is a T1 and T2. Those patients are all amenable either to be treated by mastectomy or lumpectomy. And the patients that are T3 or T4, the T3 lumpectomy is usually, it would have to be a woman with a very large breast to be eligible for lumpectomy. And the patients that have skin or chest wall involvement are not eligible for surgery up front. So the surgeon has to take all these things into consideration in making a recommendation. So we have now changed a little bit our approach to the axilla and to assessing lymph nodes, and they've become an important part of our thinking and our decision-making up front. So we can either examine the axilla to see if there are any nodes involved, or we can also use the assistance of an ultrasound machine. And here I show you some shadowing of enlarged lymph nodes that when you test them with a fine needle aspiration biopsy, we demonstrated cancer cells in there. And so these findings are taken into consideration in deciding how to approach the surgery in a patient. So here to reiterate, if the tumor is small, it's usually amenable to lumpectomy, as shown here. And even sometimes, like the initial picture I showed you, which was the same patient shown here, where the skin looked involved, that patient we were able to treat her by lumpectomy, and not because the skin was involved locally did we need to do a mastectomy. But the other times, as shown here, when there is nipple retraction, when you have a very large tumor, as the circle shows here right behind the nipple, then it's hard to do anything but mastectomy, as shown here. But the mastectomies of today, I think our awareness has been elevated with the news lately from the surgery with Angelina Jolie, which is, I think it's good. Patients learn from this. We have much better ways than yesteryear of treating patients with mastectomy. We have sophisticated implant devices that allow us to recreate a mound in a way that is, rather acceptable, and certainly in clothing, no one need to notice that a woman had a mastectomy. We also have tissue reconstructions. This is not a very skin-sparing tissue reconstruction shown on the left breast. But nowadays, we've veered towards doing really far more cosmetic mastectomies, as Angelina Jolie had, and as shown here, that you can recreate the mound by saving the entire skin envelope with the nipple. You can fill it in either with an implant, as shown on the panel on the left, or with the patient's own tissue. So I think the trend is, and the publications are coming out slowly, is to offer this more and more. In fact, many of my colleagues around the country feel like me that most women who need a mastectomy are probably eligible for a nipple-sparing mastectomy. They don't, just because the tumor is bigger, as long as the margins are negative, then it's good to go with a more cosmetic mastectomy. And so I think that sometimes the surgical world and the surgeons themselves are oftentimes more conservative than they should be. So it's important for patients to be their own advocates and know what the options are. So oftentimes after breast cancer surgery, be it lumpectomy or mastectomy, radiation is needed to achieve better local control. Typically, lumpectomy patients all should receive radiation therapy. In the initial trials, patients received whole breast radiation therapy. Now we've completed some trials that are going to tell us whether partial breast irradiation is as good as whole breast, and we need to see this. We need to allow the long-term follow-up to tell us whether they are equivalent or not. You cannot look at things often in medicine in very short-term follow-up because you may not really see some of the adverse effects, as both as Dr. Love just alluded to in her last session. And there are instances when we may be able to omit radiation altogether. And we know that radiation has some acute effects, but also has some long-term adverse effects. And here, sometimes mastectomy patients need radiation therapy, and this complicates some of the decision-making that both the oncologic surgeon, like myself, have to go through in conjunction with a plastic surgeon. So lymph node surgery, this is another area where things have changed a lot in our field. Typically, whether women had involved lymph nodes or not involved lymph nodes, all the lymph nodes were removed, even in the first 15, 20 years of lumpectomy. And so one of the side effects is, of course, greater immobility and potential swelling of the arm, which we call lymphedema. So still, when the lymph nodes or many lymph nodes are involved at the time of surgery, the right thing to do is to remove those involved lymph nodes. But for over a decade now, we've developed this procedure that for women who have no tumor in their axillary lymph nodes, that we can avoid removing many lymph nodes unnecessarily and just remove a few by a procedure that we call lymphatic mapping sentinel node biopsy. And we use a dye, which I use a picture here because it's much easier to see than you cannot see radioactivity, but either a radioactive tracer or the blue dye to find these lymph nodes. And if these are negative, we can avoid taking unnecessary lymph nodes, and we avoid some morbidity that way. So these concepts have been vetted in clinical trials. In fact, there's a new clinical trial that is the data was published, presented about a year and a half ago, and when there is very low level involvement of lymph nodes, just one or two, that just radiating the breast and some of the low axilla, which inevitably is encompassed in radiation of the breast, may be sufficient, and that even those patients can avoid having all the lymph nodes removed. So we've really gone from an era where we had more radical surgery, removed all lymph nodes no matter what, to really almost not removing lymph nodes unnecessarily. The other arena, the area where things have changed, is that surgery often comes after chemotherapy. We do chemotherapy up front and perhaps more and more hormonal therapy up front. And we make these decisions based on some of the molecular markers of the tumor. That's part of the early decision making. And especially if patients have, if all these molecular markers for estrogen, progesterone, and the HER2 oncogene are negative, or if the HER2 is overexpressed, those are really common reasons for us to give systemic therapy up front. So here's just to show you that sometimes, even though we have a great response, you see a very dense whitish tumor full of calcifications on the left, and after chemotherapy on the right, the tumor seemed to have disappeared, but these calcifications stayed. So we still have ways to improve that. The imaging sometimes is equivocal even after chemotherapy, and we can't know until we do surgery whether there is residual tumor or not. In this case, this patient, even though the clinical response seemed to be 100%, once we did the surgery, she still had a lot of residual disease. So just to move along, some of the other arenas that have been touched upon today is that surgeons can have a role both in risk reduction by advocating we have a few drugs, tamoxifen and raloxifene, that in patients who are high risk, they can be given this and reduce the risk. But some women who are very high risk or who carry a mutation and have a higher predisposition for developing breast cancer may choose to have prophylactic surgery. And these are always difficult conversations, and I think only about a third of women who are mutation carriers choose this path. So we think that perhaps we overdiagnose the disease. We certainly are diagnosing about 55,000 new in situ cancers a year. These are non-invasive cancers, and the standard treatment has been either lumpectomy with radiation and hormonal therapy or mastectomy. This may be one arena where we overdiagnose. But the silver lining is that we are talking in our clinical trials groups about the end of surgery for breast cancer. We're looking at ways if we can define through imaging and needle biopsies after we give treatment up front if the tumor disappears to avoid surgery altogether. So that will be coming, I think, out over the next decade. And also that we're looking for new modalities such as three-dimensional ultrasound and tomosynthesis to diagnose cancer early. And lastly, I want to finish with something that we're borrowing from our obstetrics colleagues, is that we're looking for even other ways to diagnose breast cancer early. One example of this, we're exploring some studies looking at cell-free DNA, which is used for prenatal testing, and seeing if that cell-free DNA concurs with some of the cancer genes that we know are active in breast cancer. And this may be an example of how maybe in the future we'll be able to diagnose and monitor the response to treatment also of breast cancer. So we are seeing fewer deaths due to breast cancer, and I really think that we still have many questions that remain unanswered, and certainly finding a way to prevent and a way to definitively cure breast cancer remains an unmet need. So I think we have a way to go, but I think the future looks promising. So thank you for your attention.